Hi everyone, and welcome to Health Equity Teachers video on care for patients with disabilities. My name is Colleen Wong. Let's get started. All right, so here are the learning objectives for this module. Describe the epidemiology of people living with disabilities in the United States. Describe the disparities in health and access to health care for people with disabilities in the United States. Describe how to apply for a disability and the disability benefits available through federal programs. Explain the physician's role in eligibility assessments for Social Security disability. And describe the issues raised by lower extremity mobility, vision, hearing, and intellectual disability, and the appropriate assistive devices for different types of disabilities. So first, let's define disability. Identifying individuals as disabled is complex, with multi-layered personal, administrative, legal, and societal ramifications. There are various definitions of disability for diverse purposes, and there is little consensus across definitions. The medical model treats disability as a problem of the person, directly caused by disease, trauma, or other health conditions, which requires medical care. Management of disability is aimed at cure of the individual's adjustment and behavioral change. More recently, a societal model has viewed disability as a social program. Disability is not an attribute of an individual, but rather a complex collection of conditions, many of which are created by the social environment. The WHO approved the International Classification of Functioning Disability in Health, ICF's definition, and they define disability as an umbrella term for impairments, activity limitations, or participation restrictions. The broad definitions of disability can affect patient-clinician communications. Clinicians should approach clinical encounters with persons with disabilities just as they do other patients, starting with the chief complaint and then, as necessary, learning more about any impairments when asking about history. We're going to talk more in particular about mobility, vision, hearing, and intellectual disabilities. But I want to highlight that there are many other conditions and differences that may make someone disabled, some of which are invisible. Now, let's talk about the population prevalence of disability. Patterns of disability vary depending on perspective and definition of disability used. According to the CDC, about 26% of adults in the US have some type of disability. On the right side of the screen, you can see the breakdown of different types of disabilities and their prevalences. Importantly, a person who is disabled may have multiple disabilities. They are not mutually exclusive. Aging and conditions related to aging are the most common cause of sensory and physical disabilities. 2 in 5 adults over the age of 65 have a disability. Disability is also more common in non-Hispanic American Indians and Alaska Natives, and more common in women than in men. The presence of disability is also associated with poor health. This graphic from the CDC shows that adults living with disabilities are more likely to have obesity, smoke, have heart disease, and have diabetes compared to their without disability counterparts. The percentages are almost 10% higher for obesity, smoking, heart disease, or diabetes in those who have disabilities compared to those without disabilities. Adults with disability also have poor health care access. 1 in 3 adults with disabilities do not have a usual health care provider, and 1 in 3 adults with disabilities have an unmet health care need because of cost in the past year. Additionally, 1 in 4 adults did not have a routine checkup in the past year. There are many possible reasons for these disparities. We'll discuss some of them later on in this video. We talked about how the definition of disability varies depending on who you're asking. So, what does it mean to have disability benefits? Who controls it? And how does a patient access these services? Disability benefits on the federal level are distributed through Social Security disability. This refers to 2 programs, Social Security Disability Income, or SSDI, and Supplemental Security Income, also called SSI. SSDI gives benefits to people who are insured by virtue of having worked and contributed to the Social Security Trust Funds through withholdings on their earnings. SSI, on the other hand, gives payments to persons, including children, who are disabled, blind, or elderly, and they've passed a means test documenting limited income and resources. Here is a table that I put together that shows some more details about SSDI and SSI. So again, both programs are for disability. SSDI is paid for those who have worked in the past or for adults disabled since childhood, whereas SSI is paid to people in financial need. The Social Security Act that legislates these two programs is also different. SSDI is through Title II, and SSI is through Title 16. So you might hear these programs referred to by their titles. The monthly benefit through SSDI depends on a bunch of factors, but on average, this is about $1,197, and SSI is about $771 per month. The insurance that is provided through the programs is different too. SSDI provides Medicare after 2 years, and SSI provides Medicaid immediately. We'll talk about insurance specifically in a few slides. Now that we know about the two Social Security disability programs available, how does one apply for Social Security? SSDI and SSI use the same definition or criteria of disabled. And in both cases, the Social Security Office determines eligibility for disability. The patient initiates the claim either online or with an in-person or telephone interview. There are checklists available online in the Adult Disability Starter Kit section of the Social Security Administration's website to get started. Once the initial claim is in, the Disability Determination Service will gather evidence to support the claim of disability. So the service may request medical records, request medical evaluations, etc. The patient will then ask their doctor for evaluations and for the doctor to fill out the paperwork. At this point, about 30% of people are approved for disability, and those who are not approved can appeal within 60 days. So, what is the physician's role in the disability application process? The physician is not expected to decide whether a patient is disabled. They are instead expected to provide information regarding the impairment. To do this, physicians will be asked to do certain evaluations and complete appropriate paperwork. Now, as always, physicians must document all forms honestly, based on professional judgment. And this may create some tension between the doctor and the patient, especially in instances when the two don't agree. Because of the varying definitions of disability, and in our society, a patient may very well believe that they have a disability, even if Social Security disability does not recognize their condition as such. It's also recommended that physicians familiarize themselves with what's called the Blue Book. It's the manual for disability evaluation under Social Security, and it lists which conditions are considered disability and certain criteria for a condition or illness to be considered a disability through Social Security. Physicians can also make referrals to lawyers or advocates to help patients as well. All right, when someone is approved for Social Security disability, what are the insurance options? Who receives Medicaid, who receives Medicare, and who needs their own private insurance? So, after an individual has received SSDI for 2 years, they are granted Medicare eligibility. If an individual is approved for SSI, they can immediately receive Medicaid without the 2-year waiting period. This means that patients who have SSDI and not SSI, they'll need a different form of insurance coverage in the 2-year period before Medicare kicks in. This hole in coverage can create a barrier in access to necessary services. Additionally, as we mentioned, some people may have a disability but not qualify for disability benefits. The Affordable Care Act Marketplace is one place that offers options to people who have disability and need healthcare coverage. The options are available online or by phone. We talked about Social Security disability and the benefits it provides. But what are other programs and services for those with disabilities? There are a number of federal, state, and local-based services that can help with things like finding housing or transportation, or getting legal help or education. You can find a list of these programs on USA.gov's webpage in the Disability Services section. One topic that comes up quite a lot is the issue of getting a parking sticker for patients who are disabled. Parking permits, or placards, which they're sometimes called, for disabled people are issued by the state DMV. And the DMV may have a different definition or criteria of disability than the one used by the Social Security administration, and the definition can vary by state. Most state DMV or RMV websites have information on applying for the permit online. Now, switching gears a bit, I want to discuss different types of disabilities and resources and assistive devices that can help. Before doing so, I want to highlight some barriers to access in the medical system from patient perspectives. By highlighting these barriers from the patient perspective, hopefully clinicians can modify their behaviors and clinics to better serve patients with disabilities. So, major barriers include transportation to get to the medical facility, accessing the physical facilities and the medical equipment in the facilities, inadequate skills of medical personnel, and inappropriate attitudes of medical personnel, which can be stigmatizing and make people with disabilities feel unwelcome. Additionally, I think that this is an important one, the lack of time medical professionals, including clinicians, feel that they have. Patients with disabilities may require more time to explain their medical history or address certain issues. Along the same vein, here are some common pitfalls by healthcare providers that have a profound effect on healthcare for disabled people. Providers often fail to seek the patient's perspective on his or her impairments, assume that the disability is the reason that the patient is seeking care. They're unfamiliar with the assistive devices that may help their patient. They are not adequately trained to assess the disability. They do not have or make appropriate use of adaptive equipment in their work setting, or they struggle with the applications for disability benefits. So hopefully, with the information and resources in this module, healthcare providers will be better suited to address these issues and make less of these pitfalls to provide better healthcare for disabled people. So the first subgroup of disabilities that we're going to talk about are lower extremity mobility difficulties. Walking, in addition to being a form of transportation and moving, has the connotation of independence, autonomy, and perseverance. In English, there are sayings such as walking tall, standing up for yourself, taking things in stride, that show just how important walking is culturally. The physical act of walking involves many interactive components like gait, balance, strength, and endurance. Asking about physical activity should be part of the primary care evaluation. A patient's ability to walk distances has been used as an indicator of cardiorespiratory endurance. So asking a patient with COPD or heart failure how far they can walk provides information about the severity of those diseases. One way to evaluate walking is called the Get Up and Go test. This has been validated for elderly populations. So the test is simple. You need a space, a chair, and a stopwatch. Instruct the patient to rise from a seated position, walk 10 feet, turn around, and return to a seated position in the chair. Taking more than 30 seconds suggests higher rates of dependence and risk of falls. Taking less than 20 seconds suggests independence for transfer and mobility. Getting patients to describe their walking and difficulty walking can take careful questioning. Important aspects to inquire about are distance one can walk, any pain or muscle weakness with walking, and any past falls so that we can assist in designing strategies to prevent future falls. With that being said, primary care clinicians are typically not trained to perform detailed functional evaluations or recommend specific exercises or other clinical interventions. Since primary care providers such as internists and family medicine doctors are not trained in detailed evaluations or specific exercises, they should make appropriate referrals to physical therapists and occupational therapists. PT and OT are important resources for providers and patients. Here are some guidelines as to when to refer to patients to PT versus OT. Clinicians should refer patients to PT when they are adapting to new disabilities, have significant balance or gait disturbance, have significant range of motion or strength impairments, need assessment for mobility aid, need training in the use of an ambulatory aid, have seating or positioning problems with a wheelchair. And clinicians should refer patients to OT when they are adapting to a new disability, need assistance with basic or instrumental activities of daily living, display limited judgment about safety, need a splint or orthotic fabrication, need adaptive equipment for work, or require assessment of home environment for possible modifications. Patients who have a hard time walking or are unable to walk may benefit from ambulation aids or wheeled mobility aids. There are two broad classes. Ambulation aids include canes, crutches, knee walkers, and walkers, which assist in ambulation, whereas wheeled mobility aids, such as manual or electric wheelchairs, replace ambulation. Historically, mobility aids carry stigma, so patients may not want to use an aid even if it may help them. The language is also shifting surrounding wheelchair use. Phrases like wheelchair bound or confined to a wheelchair imply passivity and are simply wrong. Today's preferred phrases are wheelchair user. Insurance companies, including Medicare, will only pay for ambulation aids and wheelchairs if it's medically necessary. This creates yet another barrier for patients to get the aids that they need. As a doctor, you may be asked to write letters to insurance companies to indicate medical necessity for equipment. Here is more information on types of ambulation aids and when to use which aid. Canes, crutches, knee walkers, and walkers require adequate shoulder, arm, and hand functioning. Canes can aid balance and offload weight. Multiple styles of canes exist: standard, offset, multi-legs, but unfortunately, little research has explored the optimal care for different situations. So it often comes down to personal preference and availability. In all cases, the cane needs to be a proper height. To improve balance, the cane should be held in the dominant hand. For offloading weight, the cane should be held in the hand opposite the weak or painful leg. Crutches, unlike canes, can bear a person's full weight, assuming that the person has sufficient upper body strength. The two classes of crutches are auxiliary or forearm models. Knee walkers can be used by individuals with foot or ankle impairments. They do not require upper extremity strength, but do require significant attention from their users. And knee walkers cannot be used on the stairs. Many models of walkers now exist. There is the standard 4-point walker without wheels, walkers with wheels, with brakes, seats, baskets, and depending on their style, walkers can increase stability and balance. Wheelchairs are not all created equally. Engineers and material specialists design wheelchairs and wheelchair cushions to maximize safety, comfort, and functionality. And they have adequate support and padding to minimize the risk of pressure ulcers and to maximize stability. For people with money or insurance coverage, many options exist. However, some people can only afford inexpensive and suboptimal models that may not meet all of their needs. Another common disability is blindness or low vision. First, let's define legally blind. As its name suggests, the definition of blindness was determined by the government, not medical professionals. And importantly, legally blind does not mean total loss of vision. It's defined as central visual acuity of 20/200 in the better eye with correction. So that's with the best contacts or glasses for that patient. Or a field of vision of 20 degrees or less. About 80% of those who are legally blind can see shadows, light, colors, or images. In the United States, about 5 in every 1,000 people are legally blind. Low vision can compromise mobility and independence of daily activities of living. They can increase the risk of falls, and it's been associated with depressed mood. So it's important to ask your patients with low vision about these parameters and to screen for mood disturbances as you would for any patient. Assistive devices such as computer screen readers, books on tape, and talking appliances can help those who are blind or with low vision. In the clinical setting, office staff and clinicians should be trained about communicating with persons who are blind or with low vision. Introducing oneself and asking what kind of assistance persons may want are the first steps. Importantly, the blindness or the low vision may not be the chief complaint, so physicians should not automatically assume that vision should be the first topic discussed. Unfortunately, clinicians rarely provide information in accessible formats to patients who are blind. This is particularly important in medication management. It can be helpful if clinicians record all pertinent information about medications in a form that's useful for the patient, such as Braille, large print, or audio cassette. There are websites and organizations that offer extensive listings of various programs, services, and resources to help assist persons with visual disabilities, including learning how to read Braille. I have links to American Foundation for the Blind, American Academy of Ophthalmology, the National Federation of the Blind, and Future Insights resources listed on the slide. Now let's move on to hearing disabilities. People who are deaf or hard of hearing may have no functional hearing or enough residual hearing that an auditory device provides adequate assistance to speech. 9% of Americans have hearing loss, and age-related hearing loss is the most common. But hearing loss can be congenital or affect children too. 1 in 1,000 children have severe hearing loss. Some assistive devices can help people who are deaf or hard of hearing. Hearing aids, assistive listening devices, cochlear implants, and telecommunication technologies, among others, can be helpful. Hearing aids amplify sounds with different settings to target different wavelengths. Assistive listening devices aim to improve the signal-to-noise ratio, allowing people to hear better. The process is technically equivalent to putting a listener's ear closer to the sound source. For sensory neural hearing loss, persons can find cochlear implants to restore much of their hearing. Experiences with cochlear implants are highly variable, and the technology is very controversial, especially among deaf parents who wish that their deaf children be raised in the deaf culture. People who lose their hearing later in life typically have speaking skills comparable to persons who are not hard of hearing. However, the communication skills of prelingually or early deafened individuals may depend on their early education. They may communicate via American Sign Language or via lip reading. And in the clinical setting, patients may need a sign language interpreter or readable lips to communicate. So this may mean wearing masks that are clear around the mouth or other strategies. Here are some websites and organizations that offer listings of various programs, services, and resources to help assist persons with hearing disabilities. I have links to the National Association of the Deaf, American Speech Language Hearing, the National Deaf Center, the Hearing Health Foundation, and My Deaf Child's resources listed on the slide. The final type of disability that we're going to discuss is intellectual disability. Intellectual disability is one characterized by significant limitations in both intellectual functioning and in adaptive behavior, which covers many everyday social and practical skills. This disability originates during the developmental period, before the age of 22. People with intellectual disabilities may need accommodations at school or at work, and depending on the patient's ability, they may need a medical decision maker as well. To make the clinic more welcoming and appropriate for patients with intellectual disabilities, always presume competence. Talk to the patient rather than their caretaker. Also, ask permission and let people know what you're about to do. This is important for all patients, but especially those with intellectual disabilities who may be scared or anxious in the clinical setting. Try and take your time and accommodate the patient's preferences. These small factors and adjustments can really make a difference in the healthcare of patients with intellectual disabilities. And that concludes our video on care for patients with disabilities. Thank you. Bye-bye.